It's kind of interesting, but Good morning. I call the Board of Health meeting for April 24, 2024 to order. And it looks like we have a full house. Let me know the roll call, all right? Then, Mr. Ibach, would you take introductions and guests?
Yes, so we have a staff member, Andy Wilson, he's our local emergency response coordinator, and he will be presenting the Board of Health spotlight today. So he's with us today. And then we also have two other staff members, and Lillian, want to introduce us?
Yeah, so for context, last month you met Ariana, who was promoted to project coordinator for the Public Health Partnerships Department, which means you left an opening, which we are happy to say that Angelica, who is not a new staff member, but was also promoted into the public health technician due to the fact that Ariana had been promoted. And with Angelica moving and getting promoted, we have to have a new team member, which we welcome Juliana to the health district today. So thank you. Do you guys want to say a bit about yourselves?
Sure. I've been at the front desk for about 1.5 years or so, and so I'm just excited to be in public partnerships now.
Hi. No, I'm excited to be here. I'm ready to go. Yeah, whatever.
Thank you.
Thank you, ladies.
Thank you.
Thank you so much.
Second day.
Put her right in here for a second. That's
Hot seat day.
Yeah, so thank you both for being here and for being part of the team. I will say they will need to step out due to the fact that they need to be at the front. So
Thank you, ladies.
Congratulations. All right, we are going to move on to public comment. Mr. Ibach, I have somebody here ready for public comment. Do we have any letters or anything? Then Commissioner McKinney is asked to share public comment. If she didn't know it.
Sure, thank you for that. And if there's, did you want to go make the call? Just since no one's here, I guess I can go for it. So, I just wanted to raise, an issue, really as a member of the public that I found to be, really unfortunate. And it has to do with, something that is related to our public health district, and programs. And that is, we all know that there are partners in the community who are all tackling in various ways our homelessness issues, our addiction issues. And we have many providers who offer multiple solutions. Certainly, a complex issue like this does not have one solid answer and response that is the one and only way that we solve a problem as critical as drug addiction and homelessness. So having said that, one of our service providers in this area is the Union Gospel Mission. And they are having their singular most important fundraiser that is tomorrow evening. And as many organizations do, they have invited a guest speaker. And in this case, their guest speaker is someone who promotes alternatives to harm reduction programs. He is not saying that that is the only way, but it is certainly an alternative promotion. What I wanted to raise is what I found to be a very unfortunate, what I would categorize as visceral response to this man coming to speak to an alternative solution to this problem. And we actually had members of other organizations in town who do promote harm reduction, actively encouraging people to show up at this event and deter people from going inside to raise money. And this is coming from internal emails that are sent out to the Homeless Coalition. And I can say that this information, this email, was something that was sent out by the director of Yakima Neighborhood Health, Rhonda Hoff. And I hope that she would seek out the opportunity at this point to retract the invitation or suggestion that anything related in the Yakima Herald article that called attention to this, which I will say the article from the Yakima Herald says that the Union Gospel Mission speaker promotes hate, not healing. And this again is an alternative solution being offered by one stakeholder in the community. This is not being represented as the only way. And I just want to say that we really have to be careful as a community to go down this slippery slope yet again. If you recall during the COVID response, it was said that the vaccine was the only way to get ourselves out of the COVID pandemic. And anyone who did not take the vaccine was viscerally attacked, told they didn't care for their friends or their families or their neighbors, and attacked at some point as murderers. And simply because they held a different belief on how they wanted to be a part of a solution to a complex problem. So I just want to raise this issue because it is certainly relevant and germane to the conversation that the health board has in our programs. We are promoting multi-pronged solutions to a complex issue. And I would hope that those in our community, especially our stakeholders, would represent that their way is not the only way and be wholly supportive of others who are pursuing other options to this complex problem that as a community, we all want to solve. Thank you.
All right, we are moving to the consent agenda, which will be approved as one motion. There will be no separate discussion on these items unless the board member requests, in which the event will be removed. The item will be removed. Mr. Arbach, would you read the agenda, please?
Yes. March 27th, 2024, the Yakima Health District Board of Health meeting minutes. Payment of accounts payable and payroll issued in March 2024 in the amount of $968,138.17.
Thank you. We have a motion to approve the consent agenda.
Move to approve the consent agenda.
Thank you. We have a motion and a second to approve the consent agenda as read. All of those in favor, please say aye.
Aye.
Any opposed? Motion passes. Thank you. Now we come to our Yakima Health District Spotlight today, our emergency response coordination presented by Andy Wilson.
All right, good morning. This morning, we're going to talk about emergency response and coordination at YHD. So in the responsibilities of this is planning, coordination, and response. It's a totality to get everything to work together. Everything's more effective and efficient when responding to emergencies in the county. Slide, please. So in that, we have our mandated services that YHD performs every day that we work. Even during an emergency or times of disaster, we still have to meet those mandated services. So for that, we created a continuity of operations plan, which we call our COOP. And in that, we identified all the programs in the COOP that have mandated services and essential functions. And this year, we exercised all those COOP tabletops to make sure that we identify the gaps, and then we can update that so that we can continue those services. So in the COOP, our identified essential functions are communicable disease, providing vital records, emergency notification alerts, foodborne illness investigations, sexually transmitted disease treatment, rabies investigations, and tuberculosis control. So each of these we perform every day with our staff. So those are the essential functions that we had to meet. Excuse me. We identified the staff and the resources that we needed to meet those essential functions. So the number and qualifications of the staff and the succession order in case something happens, who has the authority to make those decisions. We also identified the infrastructure needs that we need to have. So alternative locations, if the building burns down, how can we perform those essential functions? Where can we go? And the documents such as vital records papers and the IT needs. How many computers do we need to meet each of those essential functions? So the other thing that we work on at YHD for emergency response is increasing community partnerships. So developing these partnerships with the public and private entities prior to public health emergencies is essential. Never want to go into an emergency, meet somebody for the first time, trying to figure out where their authority is, what qualifications they have, what resources they have. So you want to meet those people ahead of time. So one of the ways we do that is going to the LEPC, the Local Emergency Planning Committee. That's a big committee that emergency management puts on every other month. It gets together public and private entities. The private entities are the bigger industrial facilities, tier 2 facilities, medical facilities. But we get together every other month. We talk about the future plans, what we're doing as a county to work towards preparing for emergencies, and how we can all work together. Who's got resources, who's got the availability, who's got the capabilities to meet those emergency needs that we have. We also participate in exercises. A couple of the exercises we participated in the last year were the medical response and surge exercise. It was based around a fire at the Gorge Amphitheater when they're having a big concert there. So a mass casualty incident. How are not only Yakima County, but surrounding counties going to work together to distribute those patients to make sure they get to the hospitals where they can be treated. So that was a good exercise, working with other LHJs, other medical facilities. We participated in the Columbia generating exercise, a few of you guys were at. That brought in local, not only our county, but multiple counties together, federal partners, Department of Energy, other state partners like Department of Ecology, WSDA. And we all worked together on that exercise. That was a full exercise put together at the EOC over at Emergency Management. And the Yakima Air Terminal exercise, which is more focused on just Yakima County. We did a tabletop last year, and then May 11th, we're going to do the full-scale exercise over at Sozo Field. So that will bring together all the medical facilities, fire departments, law enforcement, Department of Transportation, everybody working together there. And this will be a full-scale exercises with volunteers. So we can all get together, not only tabletop work it out, but see how it works in real time when everybody gets together. In those exercises, we identify gaps, and then we can plan for future responses that are real world. We also offer and participate in trainings. Memorial Hospital did an incident command system training over at Emergency Management. We were over there. I helped participate in that and help guide, work through how ICS would work internally for Memorial Hospital and how public health would integrate into that ICS structure. And then YHD put on the drinking water emergency preparedness workshop. So brought in the water systems from Yakima County. We had a good turnout. And those facilities are critical infrastructures for our county. So big cities, if they run out of water, it's a major problem, but they often don't get brought into emergency exercises because they're not a primary part of the exercise. So it's good to bring them in. They get familiar with us, let us know what we can offer them with resources, and let them know how they can fit into our system, ICS system, when we have a real world emergency that might affect their water system. We also work with community groups and leaders to identify resources for foreseen emergencies. So if we know an emergency is going to happen, like we have wildfires every year, we have floods, we know these emergencies could happen. So we work with these community leaders to find out what gaps they have in their resources, what they would need if this happens. If they have a big flood, where would they go? What types of resources we can help provide, or our partners, we can reach out to our partners to help provide so that when the emergency happens, it's not a long-term effect, or not as long a term effect if we weren't prepared for it. And we participate in initiatives to help reduce the effects of emergencies in the community. So that's a big one. We all know that we would love to prevent every emergency that's going to happen, but we can't do that. So what we want to do is try to get everything together, plans in place, resources in place, so that when those emergencies do happen, the effect is less than what it could be for those communities. So response and exercise partners since June of 2023. So YHD is public health. Every emergency brings in public health at some point. So we have a wide variety of community partners. It's not just local partners. It's not just state partners. We have federal partners, state partners, private entities like MultiCare, ranging from DOT all the way up through EPA. So we try to bring in everybody, and that's the goal of coordination at YHD is when an emergency happens, we know who to call. We can get the resources in there, whether it be state, local, or feds, excuse me. So you can see on here, we've got the EPA, emergency management, fire districts, even private partners like Zillow, City of Zillow, when we had the Coali Boil Water Advisory. All of those partners help us mitigate the emergency and make it go more efficient.
So Andy, a question, if you don't mind. I just noticed on there, you got sage fruit on there. And so I wonder if you could kind of talk a little bit to, what part of a private enterprise like that plays in this.
So private enterprise, if an emergency happens, so Sage Fruit was brought in there for the Olympic Fruit Warehouse fire. So when an emergency happens at a private facility, they are a partner also. They're the ones that we prefer. They are the ones that are putting the money towards the emergency. We're reaching out to them to make decisions based on evacuations. So at the Olympic Fruit Warehouse fire, smoke was going into neighboring neighborhoods. Citizens were concerned, so we worked with them to help set up hotels so people could evacuate if they wanted to. So that's how the private entities come in. If their facility is affected, they're going to be a partner, or they could be a private partnership that helps us in the emergency.
Thank you.
So increasing efficiency and effectiveness, that's the primary goal. Why we do all these different things during emergency situations. So planning, one of the main documents that we use is the Yakima County Multi-Jurisdictional Hazard Mitigation Plan. So the county goes through and they figure out, what types of emergencies might we have and how high of a probability it is that we're gonna have them. Around here, wildfires, real high probability that we're gonna have wildfires and be affected by wildfire smoke. So it's a high probability that we're gonna have it, and then they rate how much the risk is to the community. Things like hurricanes are on there. We have a really, really low probability of hurricanes, but if we did have one, it would be a high risk. So they take those numbers and they balance them out, and then that determines where we're gonna put our priorities in future planning for this, for emergencies. Once we get those priorities figured out, which ones are our highest priority, then we go through and we try to decide on what resources we need to meet those emergencies. Wildfire smoke, do we need more fire management? Do we need more staff resources? Is there equipment that we could use that could help mitigate that? Coordination, we develop public and private partnerships like I've talked about to identify authorities. That's a big one that you come into emergency. If emergencies aren't a common one like wildfire, everybody knows who's got the authority over wildfire. But if you get a different emergency, a hazmat spill or something like that, if you don't know who's got authority and somebody starts making decisions without the authority, then everything has to get retracted. It makes everything a lot slower. So identifying those authorities ahead of time is really important. Resources, capabilities, who's got authority over it, but do they have the capability to deploy staff, equipment out there, such as Yakima Clean Air Authority. They've got authority of the air quality. However, they don't have as much equipment as Department of Ecology does for measuring air quality. So we need to know who's got the authority and who's got the capabilities to help respond to that emergency. And maintaining an open line of communication with these partners during possible upcoming emergency situations really increases the efficiency and effectiveness of it. It's never good to call them up and say, hey, we've been talking about this for 2 weeks and now what's happened. So we want to let them know, having that open line of communication. Hey, this might not happen, but we're planning for it. We're getting a plan together. We want to bring you in so that you can help us work through this plan so that if it does happen, it's going to go as smoothly as possible. And response. So in the response, when emergency does happen, we use the prior planning and coordination to increase the efficiency and effectiveness of each response. That will mitigate how long the disaster lasts for, along with helping public health. So the better your plans are, the more resources you have available, the better it's mitigated for the community. So some recent responses that we've had in the last year, a little bit over a year. So we've had our 2 landfill fires. You guys have heard about these quite a bit, but we had one at DTG and Caton. Caton was a little bit different because there was a surface fire there. DTG is a subsurface fire, but essentially still a fire there. We have the same hazards, fire hazards, groundwater quality. So this was a good one. We brought in Department of Ecology with public health, EPA, brought in a lot of different community partners, the fire districts, emergency management, to determine what is the best way to get the fire out. We couldn't put water on it because we didn't want to affect groundwater quality. We wanted to measure air quality to make sure that the public and the workers are safe. So we brought in all those partners to come up with a plan, come up with evacuation plans for the neighboring citizens there, take air quality measurements. We brought in EPA to make sure that we're doing the right methods so that we can get the correct data so that we can make informed decisions to the neighbors and to the workers on site as to their health. Boil water advisories, we had 2 of those in the last year, one in Terrace Heights. It didn't affect the whole system. It was nice. Once we found out the sample was bad, we were able to bring in DOH and they were able to isolate it to a small area. You can see on the left-hand side there, the green area at the bottom was the only area that was affected by this boil water advisory. So it really was able to limit how many people were affected by it, how many people had to boil their water. We only had 1 food establishment there. So EH went out and worked with the food establishment on letting them know how they need to close down and how they need to reopen so that it can be safe. Once a boil water advisory was rescinded. So that one lasted about 2 weeks. But we worked with the city of well, actually, that was the county runs that water system. County Department of Health, us and Ecology worked together to make sure that everybody was safe on that one. Zillow, we also had a boil water advisory there. It was much bigger. It affected the whole town. Affected a lot of food establishments, so EH had a lot of work on that one, going out with the food establishments, getting them shut down properly and getting them reopened properly. We worked with emergency management and DOH to go out there. They did a special investigation to determine where they thought the contamination was coming from, got the water chlorinated, and it took a little less than 2 weeks on that one to get that one opened back up again. But that did affect a lot of people on that one. So Olympic Fruit Warehouse fire, like we talked about earlier, we obviously had the fire hazard initially while it was going on. Water quality, they put over 100,000 gallons of water on that fire. So we worked with the neighboring houses to make sure they had some shallow wells there to let them know, hey, if you see any change in water color, water taste, odor, let us know so we can get your water tested. Fortunately, nobody was affected by that. Also, the air quality, worked with Department of Ecology. They went out there with their air meters, took air samples, found out what the constituents were. It was mostly particulate matter, but we also had the concern of ammonia in the air. And these warehouses, they have bins, but they also have plastic bins. So we were worried about VOCs and other contaminants. But Ecology went out there, walked around, took air quality samples. We talked to the neighbors, let them know. We talked to Olympic Fruit Warehouse that, hey, this is high particulate matter going into neighboring neighborhoods. We would like to have a place for those citizens to go if they need to get out of their house, if it's affected them. And so they worked with us and they got hotel accommodations for anybody that needed to move out of their house for a couple of days while that smoke rescinded. And the Toppenish sugar beet factory explosion. This was a big explosion down in Toppenish. Unfortunately, somebody did pass away during this explosion. When this explosion happened, it was natural gas, so it's invisible. You can't see it. You wouldn't see the smoke from it. So we had not only did we have an explosion hazard, but we had a high air quality hazard there. And so Department of Ecology, Emergency Management, the fire districts all worked together to make sure that nobody else was affected by it. The school, the Toppenish Middle School, was a shelter in place during the emergency. We also had an unhoused population that was living down by the water tower that Andre was able to find out about. So we passed that message on to emergency management so they could go contact them, make sure that they were all safe and let them know what the hazards were there. But a big emergency that happened, a lot of agencies came together and it got resolved relatively quickly. So with all these responses, exercises, trainings that we go through, what do we do with all that information? So after every response or exercise, we do an after action or a hot wash. That's depending on the size of the response or the exercise. But essentially, we go through, we identify all their strengths and weaknesses, not only within YHD, but we try to bring in every partner that was participating in that. Once we identify those strengths and weaknesses, then we can identify the gaps in training or resources that we need or documents that we need. Once we have those, then we develop an improvement plan so that we can fix those for the next emergency that comes along or the next exercise that comes along, because it's no good to just identify your weaknesses if you don't do anything about it. So in emergency coordination and response, it's just a preparedness cycle. Start with planning. We see an emergency that we're going to foresee that is going to come along. We plan for it. We organize, train, equip, exercise, evaluate, take corrective action, and then start back over again. It's a never-ending process that we can always be improving because technology changes, staffs change, authorities change. But that keeps us always up to date as much as we possibly can for emergencies. So all those things we put together to try to meet our YHD strategic goals, delivering our mandated services with the COOP, develop a network of community partners invested in improving public health with their exercises, community meetings, trainings, and then increase the effectiveness and efficiency of the district services. So each one of those things works together so that we can be more effective and efficient in emergency situations. Any questions?
I have one question. So for long-term planning, when we're trying to think of emergencies that will happen, and since our state specifically is legislatively required us to have a stronger reliance on electric operated vehicles. So how much are you starting to plan for the inevitability where there's a mass event, flooding, there's power outages, and you're needing to evacuate a large neighborhood, but their vehicles don't work because they haven't been able to fully charge? So how are we looking at those problems that will be coming down the pike, especially when also our emergency response vehicles are also going to have to be electrified? So how are we going to really truly do mass evacuations and respond to long-term, meaning multiple day catastrophes when we don't have a reliable energy grid to move people around and provide them emergency shelter and resources?
Right now, we are in talks with Pacific Power. Horace Ward, who used to work at emergency management, is now their emergency response specialist, I believe is his title. Luckily for us, he is local to Yakima County, so he is working with us quite closely. We're actually having a meeting with him at the new the next LEPC meeting, specifically around creating infrastructure here in the county, specifically on infrastructure needs. That's what we're looking for right now. We're starting that planning process on how can we be more resilient if we have power outages, mass outages. How are we going to provide power, generators, solar power, the different types of infrastructure that we need so that we can plan for that event.
Sure. Well, it just strikes me that it would be, I think it's a bit dangerous that we have a statewide requirement to move to an electrical operated grid when transportation and all of these things are not thought out. It would seem we'd want the infrastructure first before we force people to become very vulnerable to these type of events. So perhaps with your input, the state will see through to maybe invest more heavily in infrastructure before requiring people to give up their gas fuel injected engine.
If I may add too, I think we're definitely under-resourced in terms of infrastructure here. When people talk about using an all-electric vehicle, I'm always concerned about what would happen if the pass closes and they're stuck on the actual pass. And one of the things that happens with electric vehicles is, as I understand it,
Right. Apparently the legislators couldn't think of that, but you must be much wiser, so.
well, I'm worried about my family and the fact that, it's one thing for a state trooper to come with a tank of gas for you and another to be able to fully charge. As I understand it also, some of these battery cells, if they fully deplete, do not quickly replenish in terms of power. So
They're also
we saw,
combustible, which poses yet another very, very tricky situation.
so we saw around the country during these really massive snowstorms, cars that were abandoned because they just couldn't work. And so there's a vulnerability there. It's also something that we've talked about internally in terms of that really cold weather snap that we had last winter, that it really highlighted some vulnerabilities that we have in rural Eastern Washington, which we're using now as a fulcrum, if you will, to have more conversations about infrastructure with the state. And I'll share some in my report.
Perhaps we should have gasoline and diesel reserves on hand, or those archaic engines that still run on gasoline and diesel.
Perhaps we should save
That's
some
called a
of
gas
those
station, though.
Yeah, so don't sell all your gas cars. Any other questions or comments?
That's great work. Thank you.
Yes, thank you. I do have a question. So you talked about the cycle starting of planning and then coming around again. Do you specify that like fires, the different cycles? And how often do you test each cycle for each type of events?
Yeah, using the hazard mitigation plan that the county puts forward. So we kind of use that as our primary, what is our primary hazard that we're looking to, or the foreseen emergency that we're going to have in the next year or so. In that one, then we decide when was the last time it was planned for, what are our resources, how often does it get exercised? And if it hasn't been a while, then we'll move it up to the top of the list. We can't plan an exercise for every emergency, so we try to prioritize on those.
Thank you. Any other questions or comments? All right, thank you very much.
Thank you.
Next on the agenda is our agency report. We're going to start with Executive Director Alejandra Fresco.
Morning to the board. Thank you, for guests, and, we're grateful to be here today. I want to begin with just some quick updates. We have, had our attorney, Chris Murphy, who's representing us with landfill, submit to the Solutions to All Hearings Board. And so that's in process. There'll be more to share, but it is following the expected process that we all discussed. So you have questions, that's where I'll leave it, because it's just something that's out of my realm of expertise.
And Andre, on that, we're several months away from actually having a hearing, right? It's gonna be at the end of the year.
I wouldn't presuppose how that works, where we navigated the court process, and now we're going through the pollution control hearing board for a second reason. So we're before them for two different reasons now. The original concern we have, and now being told that we have to navigate through the pollution control hearing board versus the court system. Am I saying it correctly, James?
Yeah, the one scheduled in December is for the appeal that was brought forward by the Caton landfill. To try to overturn our decision to not renew permits.
So there'll be more to come. I also wanted to share some really complimentary updates on our team working on the breast circle cancer program. We met last week with some of our colleagues around the state at a meeting, a public health meeting, but I had a meeting specifically around BCHP, and it went really well. We have colleagues in other Eastern Washington counties whom we've been helping as part of this prime contractor relationship. So as to recall, we expanded into the Spokane region all the way up to Canada in support of the fact that they didn't have a hub as we have here in Yakima County for surrounding counties. But it is a heavy lift, and our team has done a great job. And I was very pleased to hear the compliments from our colleagues, because the communication has increased, the partnerships with hospitals have increased, and of course, the services to local women have increased. And so the part of the conversation was what we at the board have discussed, which was the transition of this program back to that region. And so they're very interested in it, embracing it. And so we're going to play an advisory role, assisting them in that process, and also being a resource for some of the efficiencies that we've created here. So we're very pleased about that. I want to thank the board for their understanding and in allowing the health district to be a resource for other counties in a time of need. But again, it's for others who need it. Thank you.
I just want to recognize for the record that Catherine Saluskin is on by Zoom today, and Dr. Mark just joined the meeting. Thank you.
Andre, I would just offer a possible amendment to your comment to say that services offered to both men and women, because
That's true. Yes, and I was thinking, unfortunately, it's always confusing for me. It used to be the breast cervical cancer and colon program, no longer colon, so it keeps me up. It's still called the BCCHP, but the one C. I always get tricked. It's hard, but thank you. So those are our updates. I wanted to thank both Andy and our team and Ryan. When I first arrived here, we did not have a full-time emergency response coordinator. We had a portion of a director's time, and we were doing very little in that program. The state was expecting very little from our health district in all jurisdictions. I've always felt that emergency preparedness is very adjacent to public health, and it should be a much larger conversation. We were, if you think about the typical emergencies, public health doesn't come first of mind, but we are very committed to the health and welfare of all individuals in our county. So we worked for years to increase funding and increase the relationship with the state, which allowed us to increase our relationship with the Yakima Valley Office of Emergency Management and our partners around the county, which has aided us quite well. And so the reason that we were able to employ Andy full-time is because of increased funding, but it's more than just the funding. It's the fact that we are at the table having conversations that, as Andy appropriately pointed out, allow us to have a perspective and share that in an emergency. So we're very pleased about that. And so I wanted to share with the board that we've actually been in discussions with Tony Miller at the Yakima Valley Office of Emergency Management, going back to our discussion earlier about the cold snap we had and the concerns we had and the vulnerabilities we had. One of the things that's surprising in our county is that our Office of Emergency Management has a an emergency operations center that is not fully functional. And I don't want to get into specifics, it gets very technical, but the term they use is warm EOC. Essentially, there isn't a place where you can flip on the lights and immediately start working. And so that's again a concern in terms of being under invested in Eastern Washington. So Tony and I have been discussing it. Tony has taken a great lead with the support of his board, again, on behalf of the membership of the Yakima Valley Office of Emergency Management, which is the county and the cities in our valley, to approach the state about creating an actual emergency operations center using state and federal funding. The reality, though, is that to do so, you have to have an architect and then you have to go through a design process. We've been able to work with our partners at the state through our funding, through our preparedness grant, to pay for the design of that facility. So we're very excited about that because it increases our partnership. It's part of what we've discussed as a board here, that we want to serve as a catalyst. Not interested in being in charge, what we're interested in is being effective and certainly expanding opportunities for people in the valley, and also multiplying the investment we make of time or partnership or money. So the exciting thing for us is that it's part of our grant, but the state has approved with funding from the federal government to allow us to invest in this business, which we've done before when we were looking at a generator for the State Fair Park, and Ryan was part of that. And it was a lot of work, but it's really exciting because that means, again, we are adjacent to the process, but allowing the Office of Emergency Management to not have to raise its rates to members. It doesn't have to use its own funding. It allows for us to invest in a process that multiplies the impact without really changing any of the partnerships. So we're very excited about that. We're on deadline. It's always an interesting struggle with grant deliverables and contract deadlines, but we're very pleased, and I want to share that Tony and his team and our partners around the county have been exceptional partners for us in terms of being able to respond. And we have more emergencies here. We have environmental hazards. We've had multiple situations that don't happen in other counties, like multiple landfill fires. We have concerns around smoke all the time in the hot season. So this is our investment, which we're hoping we're able to make more of in the future. So any questions? That would be, I'd like to share.
I just want to thank you for moving forward with that, having attended a couple of the exercises and realizing the immensity of the gap between, well, what do you call the warm area and an area that's really ready to go. So.
I don't have a question. I would just thank you for being willing to move some of those funds forward for that design. I mean, that there really is a gap we have to meet.
I would just add that we probably, another issue that is also being highlighted and worked on is the communications aspect. Because the gaps in communication amongst all of our emergency responders is significant. And that is also something that is very strategically being worked on amongst all the similar same partner agencies as well.
You mean in terms of the technology for communication?
Communications for technology, the actual method, not all of our emergency responders utilize the same radio system. And without, again, going into too much detail, we think it would be better for everyone if our EMS and fire and law enforcement professionals were all able to be on the same channel. I'm oversimplifying, but let's just.
No, I'd love to talk to you about this. This has been a very vexing concern throughout my career, something that I saw during 9/11, and certainly something that's happened in every community that I've been in, is that different jurisdictions, different disciplines purchase different communications equipment, which is understandable, but has inherent flaws. And also, as I understand it, there's areas of the county where there's still dead spots. And so we have law enforcement, emergency response, fire, where they can't communicate, which is dangerous. It's a very hard coordination to do. It's expensive to do, but I think it's very valuable. And the idea, again, of some of the things that we work on with our team, the incident command system, the ability for people to communicate, to understand their roles and responsibilities, to work in partnership is not possible if you can't speak to one another. So yes, we're very interested and we'd happy to support that.
Great.
So that's all for me. Thank you.
All right, any questions for Mr. Andre? Let's go. If not, we will move on to our Chief Operating Officer, Ryan Nybuck.
Okay, we do have a guest that has arrived. I don't know if we can introduce.
is, would the, board be open to having public comment at this point? Introducing a guest? Consensus, yes?
Yeah. She was here last month. but,
Okay.
Good morning. Thank you for having me. My name is Jennifer Maxwell. I'm a family physician. Another one of my roles is that I am the president of our local chapter of the Washington Academy of Family Practice. And so one of the things I am interested in is seeing how we can partner with the health district about informing family physicians and hearing that one of the goals is working with community partners. That is one of the things that I was hoping to build eventually, of maybe having someone from the health district come to one of our meetings to come talk to our family physicians. Thank you.
Thank you very much.
Thank you.
All right, yep. All right, so the first thing I want to bring up to the board is we are in the final stage of our pre-design process for the remodel, of the health district. And so we should, what we're doing right now is we've received a couple of different options of designs from the architect. And so we're just kind of taking what works best for us, the best options from each design and put them together. So we should have a final pre-design in the next week or two, and then it'll take another week or two to do a cost analysis. And so maybe perhaps by the board meeting next month, we could have some more information on what the design looks like and the cost. Yeah, and we have both an executive committee and an advisory committee. So we do have a lot of input from staff members from all these different areas that will be using it. So we're making sure that we value the input very much. And then the other thing that I want to bring up is we are in emergency preparedness planning for H5N1. Melissa will talk more in her report about what H5N1 is, but have been told by the State Department of Health that we need to have plans. So if we can get a case or get multiple cases in animals or humans, that we're prepared for that. And so we are preparing for that, coming up with a plan, and then we'll have more information on exactly what that is. That's all I have.
Thank you. Any questions, Mr. Steinbach? Hearing none, we'll move on to our financial report from Jake Porter.
Good morning, everybody. We are reviewing March's financials in the quarter one for 2024. Page starts on page 10 in the Board of Health packet. So for month of March, we had a gain in excess revenue of $233,000, bringing the total for the year. Our allocated budget for revenue is 2.9 million, and our actuals are right there, right next to it, it's 2.9. For expenditures, our allocated budget through the month of March is 3.1 million. The actual expenditures through the month is actually closer to $2.6 million. Any questions on the summary page? Please. Moving into the income statement here. So kind of looking at some of the monthly differences, we did have a contribution from the Anytime Foundation for $50,000. We'd completed some COVID surveys. And so that was a non-governmental contribution that played into our large gain for the month. Some other factors for that gain, it wasn't, normally we have generally one large thing that happened during the month that creates a large gain, but for this month, there's multiple different things that affected that. We had a gain in flex revenue, and our investment income continues to be the star month over month. For the year, if you look at our year-to-date for investment income, it's $460,000. So that's driving a lot of our gain on the year. Moving down into the expenses, we're still have a position that has not been filled, and that's one of the reasons for the difference in the payroll expense. And then our enhanced and our capital expenditures, as Ryan's talking about, we're working through building expenses now. Nothing, same trends as we've had in the past few months for the expenses. Is there any questions for this page? Moving into the next page of the income statement. For the small tools and equipment and asset replacement, we had a large expense this month. We purchased another 2 Subarus out back. So we're geared up for vehicles, and so Well, you use a lot of gas, I guess.
They were in EVs, huh?
None of them are EVs, no, as Andre said, we really targeted for all-wheel, four-wheel drive vehicles for the weather here. As we all know, 3 months out of the year, it's difficult to get around, and we certainly wanted people to not get stuck anywhere. Any questions on the income statement? Moving into the programs. Nothing again here, I'm gonna really speak to you specifically unless there's any questions. FPHS, the clay colored section is our largest of our programs. Unless there's any questions, I'm not gonna speak to anything. All right, next page. Our real, our real flexes, our real, valleys and hills are in the EH program. That's gonna start to even out as we get through the year. Expecting solid waste to be, maybe a little bit, some losses in that just because of all the time and devotion that we're spending in that. We have an ecology grant that helps out with that, but that's a 75-25% split. I'll reimburse us at 25%. And again, EH is very turbulent during the beginning part of the year. I expect these to kind of start to even out as we get in. And then there wasn't a gain for the EH programs because spring has sprung now. We're starting to see those on site and those type of activities. Any questions about the second page of the program? Okay, moving into the cash flow for the month of March. We had a slight decrease in cash equivalent. That was expected. We have our FPHS funding and our dollars coming in January. Sometimes that, we'll post January 31st, and then February doesn't get posted until February. So that was the increase that you're seeing there, but we'll expect these to tick down until June and July, and it'll tick back up. Any questions? Thank you.
Thank you, Ms. Porter. Any questions for Ms. Porter?
It's not gonna be long to our health officer or Dr. Bush.
Just in time. So, we can talk briefly about measles and H1, H5N1, and Melissa will talk about it more in detail. Last meeting, I would like to just extend what I said a little bit. Measles keeps coming back to the United States, so it wasn't here for a long time, but people are coming in from other countries where it's endemic. So if they're unvaccinated or under-vaccinated, which means the vaccine they got was not effective because the cold chain was broken. So what the cold chain is it's manufactured, it's refrigerated, it's shipped refrigerated, and it's taken to various villages and doctors refrigerated. If that refrigeration breaks down for some reason, or there's transfer and it takes too long, then the vaccine doesn't work as well. So they're almost like an unvaccinated person. So in certain countries, there's enough measles circulating around that the population of under-vaccinated and unvaccinated patients maintains it. In these countries, there's 10 of them. And I hope I pronounce these right. Kazakhstan, Azerbaijan, Iraq, India, Yemen.
Kyrgyzstan.
No, it's Kyrgyzstan, yeah. Too many consonants together. Pakistan, Ethiopia, and Indonesia. So if a person from those countries comes into our country with measles, there's a 10-day incubation period, so they could get here and not know they have measles and then become sick. If they come in contact with a US citizen who's under-vaccinated or unvaccinated, that citizen may pick up measles. Actually, it's fairly likely given how contagious it is. It's the most contagious viral illness known. So there's outbreaks currently in every region of the world due to the same event. The other thing that happens if a US citizen travels to a country that has endemic measles and is unvaccinated or under-vaccinated, they may catch it there and bring it back. So that's ways that measles is propagated. And I want to say a few words. If there are any questions about measles?
A quick one.
Sure.
If a person travels to the endemic areas and then comes back, is there any isolation period that they're put through from a travel standpoint?
Great question. 10 days. So just stay away from people for 10 days.
But is that required or voluntary?
I don't know. I think
Voluntary.
I think it's good advice.
Yeah, right.
Now, it's also a good thing to segue into about how important it is to go see a travel medicine doctor before you go, because they'll look things up. There's a publication that CDC puts out regularly called the Yellow Book, and it has the countries that have any of these communicable diseases. So if you're going to a country, one of those that I mentioned, you'll get a booster for measles, even if you've been vaccinated for measles again. And the current vaccines are constructed a little better and actually work better than the older vaccines that many of our kids got when they were growing up. So that's among the vaccines that are recommended. If you're going to a country that has cholera, typhoid, yellow fever, all those vaccines. Unfortunately, we don't have a lot of travel medicine experts. So I do see some.
Dr. Barth, Catherine has a question. She's wondering if there's any cases in Catherine.
To my knowledge, none. And Melissa would find out about it right away. So, fortunately.
Dr. Varg, if I may add a non-scientific perspective, with as much displacement as happening around the world right now, you also see an increase in diseases because people are literally living in different places. They're not following up with their same exams or routines and so forth. And that translates to things that happen to
Over 10 million people have entered our country illegally since January, so the amount of disease that's come across our southern border is immense.
Well, it's any border, because they.
Well, ours is open versus other borders that are closed.
Let's say if you're coming in from Iraq, you'll probably cross through other areas. So rather than through Mexico, it's certainly possible to find that route because it is easy to
We've
go.
got Chinese going through the southern border, so it seems to be an easy way in.
And fentanyl.
True.
So just broad strokes about H5N1. And as I said, Melissa will give details. This is an animal strain, and it hasn't been seen in the United States very much. The first case was identified in 2022, and a few more cases. And these are in animals. Right? There was one human case previously in that 2002 cluster, and then another human case has emerged. And they're finding it in cattle and probably eventually poultry. But I wanted to talk a little bit about how these strains are made. So when you have close contact between human and animals, which are infected by various flu viruses, you can see one or more of these viruses in the same animal. Let's say an avian virus gets into a pig, and a pig virus is already there. There could be reassortment between those two viruses that are developing in that single animal. And then if you're exposed in that reassorted one, what may randomly turn out to be highly pathogenic for humans, or it may be highly pathogenic for poultry, or both. It all depends on how these parts of the influenza virus are reassembled. That usually happens in China because of the large number of animals and people that are living close together, and the birds will carry it along migratory patterns. So when you hear that, this is what's happening in China, we're going to make our vaccine against China, that's because the migratory birds will carry it through their route, which is up through China and Asia, over through Alaska and down through North America. That's why we're always that much ahead of the game by looking at what happened 6 months ago in China. So this funny property that allows recombination of the various parts of influenza virus in animals is what eventually starts that movement through into humans. Not many of those reassorted things aren't pathogenic for humans at all. And this particular virus, most people are, well, the two people that have gotten it haven't been severely ill, but in other areas of the world, there have been some severe cases. So.
Dr. Berg, I think it's interesting that you just highlight an important point, which is that the pathway and to look to China as something that was well known and something that was planned on. And yet when it came to COVID, we just immediately ruled out that possibility, even though all of our best science and data showed that that was the best practice to do. So it's a bit mystifying, but nonetheless, we figured it out.
Yeah, we had cases before the case that came into Evergreen Hospital in Kirkland. And he happened to come from Wuhan, which is where people think it started. But cases were probably already here because the speed with which after that first case and all over the country, other cases, particularly in New York, were found, it probably was there already and starting to spread when this guy had come in and got sick on the way over. And he was identified early on. So because the Chinese did work really early on and were letting it, pushing it really early, a lot of things were known that were very helpful, particularly the sequences of the virus that led to the eventual development of the vaccine. And then when things got really bad, they kind of shut down the information flow. In fact, interestingly, I didn't want to really talk about color, but it's really interesting.
Well, no, certainly they did shut down information flow.
But the scientists who had sequenced it, didn't ask anybody permission, they just put it up on the web. So everybody worldwide was able to get that sequence, and it started immediately working on vaccine preparations. So, kudos to those scientists who just with great guts put it out on the internet so people could see it. So, any questions about H5N1 or measles or COVID? Or a virus is yet to be discovered?
I wouldn't open up that door.
Yeah, the questions would go unanswered.
Yes.
Okay,
Are
that's
there
all.
questions for Dr. Barg? Further questions? Is there anything else, Dr. Barg?
Well, there's lots of things, but I think
Okay.
those are the ones up in
You need a
the,
travel doctor. It sounds like he can refer you to one.
you'd have to leave town unless you see me in the next couple months before I retire from clinical practice.
Thank
Go
you.
anywhere you want, but do it in the next few months.
Next we go to disease control, Melissa Sixburg.
So I will just follow up on the H5N1. About 3 weeks ago, Washington State Department of Health had a statewide meeting that I was on, and they really encouraged us to prepare for H5N1 in the event that it would get into the human population. So they've been stressing to us to have a plan in place if an animal were to test positive within our county, and if any individuals were exposed to that animal, for monitoring those individuals for symptoms, if they become symptomatic, and getting them tested, and having a plan on who would do the testing, and places to isolate, quarantine, etc. So we've started a work group to kind of work together on that, to develop partnerships, to have a plan in place. Andy could probably go into some more details on the things that we're doing from the EH side, and the EH side, Sean could as well. You want to talk about the WCA?
Oh, yeah, so WSDA permits and licenses, milk producing dairies or confined animal feeding operations. As you all know, we have a significant number of those in Yaqui County, so it's something we have to look at. Our goal with that is to get a list of all those dairies and CAFOs, just so we can be in communication with them and WSDA, and to work with WSDA to notify us if they have any plans on testing animals in Yaqui County. So that way we can be prepared to reach out to any possible individuals that have been exposed and start that process, so we can be proactive and respond timely if the need arises. So working in partnership with that, and then also concerns around unpasteurized dairy products, is one of the big concerns around how this can be transmitted. So we're looking into how to categorize where that's coming from, where it's being sold, and just being aware. But we're also want to be mindful. We don't want to necessarily affect businesses that there's not a problem right now. So we don't want to hurt businesses by telling everybody, necessarily stay away from these things. It's just something we have to look into.
And I was gonna say, the herds can be monitored by testing their milk.
The big concern is that this was found in chickens, flocks of chickens, poultry, and then it had transmitted to mammals such as the dairy cows. There's been 2 in Texas, I believe, and now in 5 states. It's been transferred to cattle, dairy cattle specifically, and they're finding it in the unpasteurized milk, like Sean said. So the concern is that it's going to be easily more transmittable to humans, especially if they're exposed to the dairy farms, to unpasteurized milk. And if it becomes into humans, then it's more likely to spread to other humans. And the concern with this one is that the two individuals, there's been 13 cases nationwide of it, 2 of them in the US. There was one 2 years ago, which was exposed to the bird
Worldwide. You said nationwide.
worldwide, I'm sorry, worldwide, thank you. 2 in the US, one was a couple years ago that you had talked about. Very, very mild symptoms, and then we just had the one in Texas that had just conjunctivitis, red eye. And so, but of the 13 cases that have happened worldwide, 5 of those were very severe and 2 of them resulted in death. So it can be, DOH stated it as over 50% mortality, so it can be pretty severe. Luckily, we haven't had that here, but that's one of the why there's CDC and DOH is very aware of what's going on and trying to plan ahead.
Besides sampling of your flock, how would you know poultry have it?
They acting different, that with the dairy cow, I know that they're producing less milk and they're acting sick. And so that we're reaching out to the dairy farms as well as part of our work group to educate these farmers how to recognize when their cows are acting different. And then we can coordinate with WSDA to get them tested.
Poultry, they test dead birds. So, and there's wild birds that also, they might die. You see one, don't pick it up. Be serious.
Yeah.
Actually, you see, your mom was right. Don't pick up animals.
Well,
And we have migratory bird corridors that come right through this county too, so.
I think we had a flock a few years ago, didn't we? Where they lost the whole.
Right.
Yeah.
Plus, you know, and certainly I'm not well versed as someone who grew up in New York City in an apartment building to talk about how agriculture works, but we do have many animals that are inseminated in other places, and so you have basically the transmission potential from other areas of the county or other parts of the state, so.
Melissa, how are you working with the dairy farm? How are you communicating with them?
That's part of our work group. I'm doing the health side. Sean and his team get to work with, and he's already reached out to the WSDA. So part of our work group is starting to get all this up and going. I believe you got a list of all the dairy farms.
Yes, I have a list of the dairy farms and CAFOs in our county. And then we'll be working with WSDA to see how they're gonna be communicating with those businesses and you know, we can create our communications and channel that through WSDA, I think would be the most efficient way, but.
Okay, so they're taking the lead on that then.
As far as handling the dairies and
Yeah.
they're the lead agency.
Well, I think it's important to note that from someone who was raised around farming and Commissioner Lindy as well with dairy, this is not something that is unknown to agriculture producers, and they routinely are checking on their livestock. In fact, I'm leave a little bit early and I'll miss your presentation because I'm going to a cattle ranch where they're going to be working some cattle and the vet is going to be there. So it's helpful to have that cross collaboration, but certainly those who his entire livelihood is dependent upon the health and well-being of their livestock and those animals are well aware and well care for their animals to make sure that they are healthy so that they can continue production.
Sure. And Commissioner, I'd like to add that too. We're well aware of the fact that we have deep agricultural ties here. And so it's our job to champion the unique circumstances here. We have a very large concentrated animal industry here, different than other parts of the state. But we also have a lot of private citizens who own small numbers of animals, and that's not regulated the same way at all, if at all. So we really want to make sure that everybody's safe. And it's really about planning, and the economics of agriculture have deep impacts to regular citizens who work at these farms and facilities. So it's important for us to get out in front and communicate effectively to decision makers at the state level that this is a unique circumstance for our county.
And I would assume that if WSDA is communicating, they're not just communicating with the dairy farms, but they're communicating with their veterinarians, because that's going to be really.
Yes.
Okay, because that's really going to be key.
That I actually,
Okay.
and been referred to the veterinarian that's with WSDA is taking the lead on
Okay.
the H5N1 concerns and be working with that individual.
And if I may, for members of the board who are unaware, we had a very tragic loss of cattle years ago. Large number, was it 1,800? In a really terrible circumstance due to weather and snow and just inclement weather. It was just a horrible situation, very hard on the farmers and their teams. But that allowed us to build a strong rapport with agriculture during that time. And so we've really expanded the definition of what preparedness is here. It includes agriculture, it includes the economics of agriculture, it includes the continuous operations of large facilities that employ many people here. So preparedness is not just assuming that you're going to have the tragedy, it's communication in advance, which is why we're starting so early.
And DOH presented a slide of all the dairy farms in Washington State, and Yakima County has a large proportion of those dairy farms. And so that's one of the reasons why we're taking this so seriously, because if it were to get into the cattle, Yakima County is going to be impacted heavily. And so DOH has started their Joint Information Center, their JIC, in preparation of this. And, you know, we want to be prepared knowing that with all the dairy cattle we have, that we could get hit hard if this were to take off. So
One last point. One of the areas that hasn't had experienced cattle outbreak bought a cow from Texas. And it probably came up with that cow from Texas. And this happened with mad cow disease too, a few years ago. The cattle bought it was made in national news.
We did.
The case was in Yakima, and it was bought in from Canada where there was active mad cow disease. So it's not just people traveling, it's livestock as well.
Dr. Varga, I have a question. So my cat brought a gift into my garage. Some kind of a dead fowl, so I should not pick it up. I think my husband swept it up and put it in the garbage, but.
Not touching it.
Didn't bring a cow home.
That's better. Just a side note about the mad cow disease. I was farming when mad cow happened here, and I was in the state leadership of the Dairy Federation. So we had, when it happened, actually, WSDA and USDA came through very well in that circumstance, and I got to see it firsthand. But I also had a lot of chance. It was kind of a 5 minutes of fame in a way, because I had the Wall Street Journal call me on Christmas Day. They did a TV, we had a local TV station do this on my doorstep on Christmas Eve. And just several, we even had a national news, NBC came in and did a national spot on our family. So it was, we still have fun looking at that video. It's kind of nuts because they
Calls and letters from my friends all over the country,
oh,
kind of half chiding me, but half being impressed that it was being dealt with.
well, the crazy thing about it was dealing with the media too, because I was doing my best. I mean, as a livestock producer, what you don't want to do is have the public panic. And so I was doing my very best in these interviews to assure people, you know, as I'm watching this process, things are going well, and I was trying to get people not to panic. And the talking head who came to interview me was very much about trying to say, hey, let's all panic, you know. So they'd have this conversation where I'd say, well, I prefer not to panic if I don't see the reason to panic. As well, Lindy may not be panicked, but there's a real concern among everybody else that, you know, this is, anyway, it was just a fascinating experience.
Any more questions on H5N1? Okay. Next thing I was going to talk about is our Child Fatality Review and Prevention Committee. We had our second meeting this month in April, and we focused on accidental overdoses. We reviewed 3 different cases of children for accidental overdose. And a follow-up, one of the big things we're working on in this program is not just reviewing these cases and then letting them drop and have no outcomes out of them. So we're continuing on, and from the first one that we did, which was suicide. We're working with Neighborhood Health during their well child checks, these yearly exams. Part of the questionnaire is, do you have firearms in the home? And so if an individual responds with a yes, we're providing trigger locks to these families to be able to safe lock their guns, because in the Child Fatality Review and Prevention meeting that we had, we identified that in one circumstance, there was a firearm that was available to the individual, that if it had been locked, maybe that impulsiveness, that rash decision, it could have been prevented. So that's one of the initiatives that we're working on for that, as well as Handle with Care. Does anyone aware of Handle with Care? Yeah, it's a great program that when a first responder or police department responds to a domestic violence call and there's children in the home, or there's any type of trauma, maybe it was an overdose or a family member passed away, and a first police officer responds, they put into the system that it's a Handle with Care, that information gets sent to the school district. And the school is aware, they don't know the circumstances, but they just notify the teachers to be aware that something happened to this child last night that was traumatic. Be a little bit more sensitive to this child and just be aware that something happened, and that if the kid is acting off that day, this is likely why. And so it's just another way to be aware that some kids might be a little bit more fragile or have circumstances where they need that little extra help. So if you have anything to add to that.
Did a good job, thank you.
So the
I will add to it. It's a Yakima school district. It's for the Yakima school district right now, but the hope is that it's going to be in every district in our county soon. So it's a model that was duplicated from Spokane. And it will follow if there's multiple children in the family, it will follow district-wide.
So now it's expanding where, like you said, it was just Yakima School District. ESD 105 has received funding to be able to expand that to 5 additional districts. I believe Sela, Wapato, were you at the meeting at ESD 105?
No.
Okay. So anyway, it's expanded out, but those can also expand out even further. And I know it's working with Comprehensive. We're trying to get every school within Yakima County set up on that.
And if I may, I would really want to compliment our partners. When we say things like adding trigger locks to a well child visit, it's not just that we're providing trigger locks. It means that clinician has to be trained in it. It has to be included in every well child visit. It's not just a question, it's now a training. And so it takes more time, which is an investment on behalf of our partners, but we're very grateful that they're doing so.
Melissa, could you comment on, or if you know anything about our neighbor county this week had a recent shooting at a school, and it shows the scourge of domestic violence and how that leads when you have an environment where an entire school has been privy to an event like this. What do they do? Because, technically all the children could be affected, the teachers, et cetera. But I mean, everybody in that environment would be potentially somebody that could benefit from counseling or, grief.
I know a lot of schools, when they have an event like that, or like the loss of a student, they have counselors on staff. This is gonna be something it's gonna be almost, like a school shooting type of thing, because it impacted so many kids, not just who, if you knew the student, this impacted the whole school. So I imagine there's gonna be a lot of extra counselors on staff helping to provide support to not just the students, but to the families as well.
They have their own staff counselors, and then they also have contracts with Comprehensive, so we did have our staff reach out.
And Washington State Coalition Against Domestic Violence is also offering resources for as long as they need.
We have a question from Catherine Slouskin. Can we read? I can't read.
She is requesting the training information so she can ensure the tribal providers are trained.
Is this on
For the
trigger locks?
Oh, for the trigger locks or for the handle with care?
I think it's trigger locks.
Catherine, did you hear the question? Do you want training on the handle with care or trigger locks?
I believe it was handled with care.
Oh, I'm mistaken.
Thank
Actually,
you.
both. Both would be nice.
Okay, and then the last thing I'll talk about is just our harm reduction numbers. In Yakima, year to date, we've had 332 unique clients with 584 encounters, 725 Narcan distributed. And then with Comprehensive, we've had 189 encounters with 28 people scheduled, and 1 patient was admitted for services, which seems low, but I want to just remind what Dr. Atterbury said last month, that everybody is on this timeline, and it's you might not be ready this week, but you are this week, and there's this timeline that everybody kind of goes by. So we believe in what we're doing out there, and 725 Narcan distributed is quite a bit. So, and then our Toppenish site is also doing quite well. We've had 149 unique individuals. Again, we just started that March 5th, so we're only in our 2nd month. 224 encounters and 356 doses of Narcan been distributed through the tribe. We had 11 positive syphilis cases out of the harm reduction in Toppenish, and we've been able to treat 9 of those individuals, which is amazing work by the staff out there. We're reaching a population that even the State Department of Health with their disease intervention specialists have not been able to target or identify. And in just this short amount of time, we've been able to identify a lot of syphilis. As you all know, we have a syphilis outbreak going on in Yakima County, so.
I would just mention that on that harm reduction, you know, the one individual that sought treatment and received treatment formally, I mean, you don't know how many peers that person has that could potentially have an effect on their decision. Because it's not the one that received treatment, that seems like a small number. It's the other ones that are contemplating it that might now go into action because they saw their person, friend, et cetera, colleague, whoever, whatever you want to describe them as, seek treatment, and maybe they were right on the verge of it. So it's an important program.
Or how many are in the thought process. I did send Victoria some statistics around reoccurrences and how many times it takes people of relapse based on drugs, and a link to an article that's pretty insightful that she'll share with the group later. But I also asked Megan Tweedy if she has that. I don't know if any of you attended the fentanyl town hall that was out at the university where the UW doctors had come and presented a lot of their research findings on genetic makeup. But I asked her if she had or could find a recording of that. I think that's pretty educational as well. And she,
Thank you, Edie. Appreciate that.
If I could ask a follow-up question on that. So, at the harm reduction sites, what, as we have the individuals come through there, how many are we able to actually have contacted by those that can try to refer them to treatment?
So that's gonna be encounter, so specifically for Yakima, working with Comprehensive, they're out there weekly. They've had 189 encounters out of the 589 encounters that we've had.
Oh, okay, that's what that meant. Okay.
Yeah, for the 332 unique clients. So they're able to get, I believe it was 40 to 50% of the clients they're actually engaging with each week and having, you know, it could be as simple as, how are you doing this week? You know, are you ready? You know, how about, you know, how did you not show up for your appointment? What happened? What can we do to get you back on track? You know, so they're making that constant communication with them so that if they reach them at the time when they're ready, then they're ready to enter services.
Okay.
And top of we actually have partnered with the tribe, and so they're out there and they're engaging with the same every single client because they're handing out the Narcan. We set that up specifically so that when they go to get the Narcan, they can talk to them about substance use disorder treatment as well.
Everyone, wow, that's awesome. Well, that's good news. I mean, because I mean, it's a good service that's being provided out there, and it's good to connect with the people. And it's good to see that we're connected with so many people. Ultimately, one of the best indicators on the success of a program is ultimately how many people no longer need it. So if we're getting to that point that they're getting approached and they have that opportunity to think about it, hopefully, like you said, if you get one that's a friend that gets them to think about it, then yeah, that's the progress we're looking for.
Yeah, and when there was a survey that was done by University of Washington throughout the state and all the harm reduction programs, and one of the findings out of it was that 25% of the people said if they had stable housing that they would completely quit using.
Two quick question. How much of this is facilitated by the new van?
The mobile.
Our mobile unit, 100%. Where they're at, and Toppenish has been surprising. You know, we purposely don't call it a needle exchange program because this is about harm reduction. And one of the things we're finding out in Toppenish is that they're not coming in and seeking needles. They're coming in for Narcan, simple hygiene, talking to the tribal members about substance use disorder. They're needing food. They're just basic human needs. But it's an opportunity for us to engage with them and interact and try to get them set up for substance use disorder.
And one thing to add to that would be just simply stating that we look at the cost of programs oftentimes in a very black and white sense of, well, we spent this on this program. What you really have to look at when you're talking about programs like this is the cost reduction in the care of these patients for infections, for cellulitis, for hospitalizations. These are all major, major costs. I can tell you that any hospitalization for an infection, you're gonna blow your mind, is about $25,000 that you're going to spend on that patient to get them through the system and out the door. Imagine what your savings are if you get 2 or 3 less infections. You know, it paid for your program for months, if not a year. So I think that it's easy to get caught up in numbers of what we're spending on this program. What you really have to be caught up is what is our savings downstream from caring for these patients that you will inevitably care for, because they don't not show up to an ER when they're infected, right? So they're going to, and so when they present to the system, highest price point of care, highest cost of care, you know, anything you can do to prevent any of that is a win.
Dr. Atterbury, you're mentioning upstream investment in prevention. We find people who have sepsis, and so just treating wound care, keeping them out of the hospital. I mean, the very real reality is we're down a major hospital in the city. There is no room for people to be in care for a number of days. And these are largely people who are indigent. So that cost is borne by that hospital, which then gets written off, which adds a tremendous amount of unreimbursable money. It's not recoverable. So it absolutely makes sense to help them when we find them. Because it is a tremendous cost savings, but also, as Melissa pointed out, the relationship and trust that's built through partnership by caring for these people and them actually having a conduit and us understanding it is wonderful. As an example, we have been really struggling with the fact that we've had this massive increase in STIs. We found a cluster of cases, and it's really assisted us in being able to reduce that in the Toppenish area. If it hadn't been for our expansion, we wouldn't be able to do it. So thank you for doing it.
You know, Andre, you mentioned sepsis. Sepsis got a tag bill for about 100 grand per patient. So I mean, these are not insignificant diagnoses. These are significant diagnoses with significant costs, not to mention a mortality rate probably in the range of 25 to 40%, depending on where they present. So, you know, the savings financially, life, whatever you want to call it, are just, I can't overemphasize, like every dollar spent, you probably get 8, 10 in return. I mean, I gotta imagine maybe higher than that. I don't know. I'd have to look at Chase for an analysis of that, but nonetheless, it's significant. I can tell you from an end user, we're the front line, right?
Yeah.
We see the people coming in, we know what we're gonna spend on them, and we're like, wow, this is preventable with clean needles. Like, that seems pretty cheap. I mean, clean needle, what, 5 cents? So
I did the analysis a couple of years ago, and I mean, it's like one Hep C case or one
Yeah.
HIV case pays for this program.
Right.
If you prevent just one, it more than pays for it. And Toppenish has the ability to be just absolutely robust with working with Catherine's team and the tribe out there. They have an advanced registered nurse practitioner out there, a nurse, a medical assistant who could, you know, be able to provide this wound care, basic needs that these individuals have that they're not seeking care for currently.
And if those aren't enough reasons and you want to make it more personal, we took our kids out to Natchez to ride their bikes because of goat heads on our lane. And there were needles where we parked the truck, so thrown on the ground. So it's a way to keep needles off of the parks and grounds where your kids play too.
And I want to thank the board for their patience in us being able to, again, Melissa and Ryan invested a great deal of time for years to be able to move this into the Lower Valley. But these are people who are absolutely in crisis. These are not people who are casual in terms of their issues. They are people who are really in need of care, and it's allowing a multi-pronged approach. It's a one-stop shop approach. And I want to thank the board for their support for this. It's allowed us to work very closely with the tribe and expand programs and work with partners who have capabilities. It's just a systems approach that's being built real time.
And I'll just say one more thing, with all the Narcan that we hand out, I read the reports from EMS first responders when they arrive at the scene. And I would say 99% of the time, when the EMS arrives on the scene, Narcan has already been administered by bystanders. So us getting that Narcan out there is making a difference in saving these lives, because by the time EMS responds, the patient's awake and because of the Narcan that's been handed out. My report. Unless there's a question.
I do have a reminder that Catherine has asked for the Handle with Care.
And
She can get some training information on that. That'd be awesome. Thank you. One second. Right, moving on to environmental health with Sean McGee.
Good morning, everybody. We have quite a bit going on in environmental health. I'll start with the DTG landfill. We received the technical review letters from the Department of Ecology on the submitted application by DTG for a new permit. We received the Ecology's official recommendation based on a number of items that didn't meet minimum requirements of the limited purpose landfill WAC 173-350. So their official recommendation was a permit should not be issued at this time. So we informed DTG that we would not be issuing a permit. And now we are in kind of the next steps. What they're going to propose as an alternative application and how they can move forward. You know, biggest items are vulnerabilities of groundwater. So getting the new monitoring wells in place, and then the protective liner and leachate collection system installed, which DTG has mobilized on. They're broken ground on that. There are lots of excavation equipment out there right now, moving some earth around to prep the new cell area for the liner. So you know, we're going to continue to work with Ecology and DTG on this, and it'll be a big effort moving forward. So don't have really any fixed timeline on when something could happen, but we'll just continue to work on it. Any questions on DTG? Okay. Moving on into our food program, we've identified there's a large need based on the food rule that came out new food rule that came out a couple of years ago. That food establishments are required to have a food protection manager, certified food protection manager. It's a really difficult course to take. It's very expensive. You need a webcam and audio, microphones. It's a barrier that we've identified. So we'll be hosting courses in-house for our food establishments to take the course and the exam to get their certification. So we have the materials and the tests in English and Spanish. And we'll be offering those on a fairly routine basis. The plan right now is quarterly, depending on demand. So, yeah, I think
For every restaurant owner, for example, every
yes,
food
any
shop?
restaurant that there's an actual food prep. So, you know, a simple coffee stand wouldn't qualify, but yeah, a mobile food unit required.
What is the
Not for a temporary food vendor. It can be upwards of a couple $100 to go through the course. I believe our costs will be less than $100 per user or per student, I guess.
And how long does it take a student to get through the course?
Through our course, I believe it's about 5 hours. Yeah, and then probably an hour-long test, 6 total. But yeah, that's why we, you know, quarterly makes sense. We can't dedicate, you know, daily, and hopefully get roughly 20 people registered in the course. Yeah.
So is that, they're required to have a person on site with this certification, or just?
On staff.
On staff.
They don't necessarily have to be there in the moment, but they have to have someone on staff that provides that more advanced training and oversight over how a food establishment operates. So they have higher training in food safety, temperature control, and processes. So
Any given establishment would just need one though, right? It's not everybody on staff, it's just one person.
yeah, everybody on staff has to have the food handler card that we've always done that. But yeah, so it's just the one person, and whoever they identify to do that. We're offering this course in person to kind of remove the barriers that we're finding. We have a very large number of temporary food event vendors every year, well over 1,000. Well, maybe not well over, but usually we break 1,000 on temporary food events. There's been an uptick since the pandemic ended. So we're going to be hosting some workshops. They're just educational sessions on how these vendors need to operate and, you know, what their permit covers. You know, don't prepare food in your home kitchen kind of thing. So we'll be offering those. We have one coming up, and I believe we have well over 30 people signed up to attend. And then we're also looking at Ranger is gonna have an offsite location that will be streaming Zoom to here, so they can join remotely. We're also looking at having a location in Sela for people to attend remotely as well.
So these are mostly for people that cater events or?
Yeah, you know, people who operate at the fairs, the festivals, they operate at events, also farmers markets. We have a different permit set up for vendors that operate weekly at farmers markets. So really popular option for a lot of folks that, you know, who are different events during the summer season, you know. So we just want them to be prepared and best educated what they can expect from the health district, and you know, keep those lines of communications open and help them out, you know, getting past any barriers they might have. We have resources.
Sean, perhaps we could take our mobile van to like these events and set them up amongst the food trucks as like, hey, here's your outreach education opportunity, both for consumers of the food and the vendors of the food. It might be useful. I don't know. It sounds corny, but I mean, it might actually work.
Yeah, you know, or if we can take payment in the field. We find early in the season, we find folks that haven't gotten their permit yet, so we typically work. But really good work, you know, being done in our food program. It is our largest program, and we meet new people every day, so we want them to have the resources they need.
You can have a map and you know, highlight the abusers and the people that are violating and say, don't eat at this truck, but go ahead and go to this.
We let people make their own informed decisions if they want to see our inspection results. We need another map. Which ones are good.
Right, yeah, right.
If you want to know where to get good food, ask an environmental health inspector.
Yeah, right.
Well, know where to get the Tums, have it on the little van.
Provide time. It's a good one. Moving down to Lower Valley, Guama. Our staff is, as you know, working in partnership with Yakima County, doing site visits, conducting well user surveys, and taking samples for laboratory analysis. To date, numbers come out every Thursday on what we've done. So as of last Thursday, we've conducted 114 of these surveys. 45 have come back with high nitrate result. These are targeted areas that the county's conducting outreach to. So we expect in the early stages of this, we're going to have more high nitrate result. That's where we based, the county's basing this outreach for them to get their well sampled is previous known clusters of where high nitrates exist in the Guama. So depending on lab results, those folks are being referred to bottled drinking water delivery services until they can get a point of use filtration system installed that removes nitrates. So good work being done in the Guama.
Sean, if I could interject there, I just want to let you know that county staff that I've talked to on this are very complimentary about the work that the health district has done there. They're, you know, the volume of people you're being able to connect with and do the tests with. So I just wanted to pass that along.
Oh yeah, I see staff hurrying out of the building every morning with the coolers and sample kits running out to the vehicle. So we're getting a lot of people scheduled, and we're getting you know, pretty high number of people reaching out to us. So it's been good. And the last thing I'll talk about is our the PFAS area, primarily in the East Sela location. We have funding through the State Department of Health, so we're going to be conducting sampling through third-party contractor to take samples in an expanded area beyond what's currently been surveyed by the Army. Great news with that is the Army shared their quality assurance plan on the sampling efforts with us and the contractor, and we'll be doing split sampling with the Army in this new area. Any contamination, PFAS contamination found over the current federal limit, those folks will be approached by the Army and basically adopted into bottled drinking water until they can get a treatment system installed by the Army. which is a whole house treatment unit. So that's initiative that will be starting on here in just a few weeks. And we're just coordinating with the sample team from the Army. They have to come out from out of state, but there'll be a mass sampling effort happening kind of east, northeast of the current PFAS area that's been identified.
Is the Army covering the costs?
This is through legislative funding through DOH that was earmarked for Guama PFAS work. So it was money that we requested, but anybody who's eligible to go into the Army's program, the Army will be covering the cost of those drinking water deliveries and treatment systems.
The Commissioner, Lindy, if I may add, it's really been a wonderful partnership and advocacy on the part of our environmental health department to recognize that there's a need in that community. And there are changes, you may want to mention these changes to the PFAS levels.
Yeah.
It's rather complex, so we're trying to get out in front of an issue. The other is reality that water tables shift, and we want to make certain that people have access. The thing that's wonderful is that the Army did accept this grandfathered concept, which means that they will, as you indicated, adopt the responsibilities immediately, which is really a tremendous undertaking on their behalf as well. So we're just trying to make certain that every private citizen has access.
Yes, and there's a few things this is going to be helpful for, but I do want to give a shout out to Lillian and her team. They did a lot of work on the scope of work for this initiative and the planning of it. So they've certainly taken on a big workload with this initiative as well. So the federal PFAS limits are changing. They're going from 70 part per trillion down to 4 part per trillion. That has not been officially adopted by the State Department of Health yet, or State Board of Health yet. But what it means is that there's going to be some work happening retroactively in the areas that have already been identified of having PFAS present in their drinking water. I know the Army is in conversations with the Pentagon around what that looks like and timelines and when they can get to work on addressing those issues. But it's something that it's going to bring a lot more potential resources to a lot more people that have PFAS in their drinking water. It also is going to allow us to identify, as Andre mentioned, water table shift, aquifer shift, groundwater flows, affect this largely, and we're going to be able to identify further the extent of the current plume, maybe where it's headed, how expansive it is, which is also, we're looking at having a feasibility study conducted on what a potential multi-well, large-scale community water system would look like that would, provide clean water. That's a long-term plan, but if it's a plan we're going to look at, we need to know how expansive a system we need to be to serve people who are affected by PFAS potentially. It also will look at the community's position on a large community water system or municipal system in the future, and allow us to engage with the community around, what that could look like and the benefit of clean drinking water. It could take us in multiple directions and should give us a lot more data to work with on future efforts.
Sorry to keep asking questions, but can you speak to why the river went from a level of 70 parts per trillion to 4? Because I think 4 is like the lowest level they can actually quantify.
That's why the limit was set there. But with, PFAS is still relatively new in how it affects animals and humans health-wise, but it has been known, for to have several different effects. The most concerning one is the carcinogenic factor. It can cause cancer. That it's a lifetime exposure limit. So, I can't say with certainty, I'm not a medical expert, but that limit is probably a lower threshold of where they were identifying symptoms long-term and folks that have had exposures. So it is currently one of the, for mass sampling, the lowest limit they could sample for, with any real, in any real timely fashion.
So will municipalities and county water systems, things like that, will they all need to be retested?
Well, the ones that have been tested are being resampled, periodically by different agencies. So, once we have the data set, we know there's a contamination or a non-detect, and if they have results that are over the 4 part per trillion, then they are now over the federal limit, and it will
That could be a whole city.
potentially.
Yes, and if I may, also, that's why the state board of health adopting those rules matters in terms of state law. So that's where this complexity is the federal government making the change, but the state hasn't adopted that yet. So we're in this gray area.
And then based on potential areas of concern, if there's a municipal system that's fed by a well, drawing from an aquifer with no contamination, that would allow the state who regulates these systems to add PFAS as an analyte to their sample. The list of contaminants they sample.
And John, if I may, and I'm sorry to keep adding, but I'm very proud of the team, as you mentioned, the team has been involved in this in terms of communication and getting information readily accessed out to the public. Ryan and Sean and others are working on the realities of communicating to municipalities, to water systems. This is part of our process. And this is why the integration of preparedness into our work is so pivotal. It's getting out in front of an issue and discussing what happens if you do have a massive impact to your water system and you can't provide water services to your clientele. So it really is about preparedness and action.
But that was the final thing on my list, I think. Talk.
Any other questions for Sean?
Yeah, I just have some. So next week, Yakima will be hosting the statewide annual environmental health conference where there'll be over 300 people attending that.
And it's a unique opportunity that our staff get to attend. Everybody will get a chance to attend certain courses and presentations that they're interested in, and doesn't get to happen very often. So we're excited about that.
It's great opportunity. Yeah. How often do they have that here?
Every 5 years.
Yeah, I think this is about the 3rd time since in the 25 years that I've been here.
We should recognize also that Ryan was just recognized for 25 years. I didn't admire his handsome shirt because.
Ryan, you don't look that old.
Oh, thank you.
Yeah, brought it up.
25.
Thank you, Sean. All right, you're going to move on to public health partnerships with Lily and Bravo.
Yes, thank you. So, my first update, I want to continue the conversation around firearm safety. So one of the pieces that'll be happening in May is with the Yakima Health District will be partnering with Seattle Children's and the Alliance for Gun Responsibility to host 2 events specifically to provide trigger locks and lock boxes to community members that are interested. At that event as well, we'll be training people on how to use these safe storage devices. So again, mimicking what Melissa's talking about that's happening in the doctor's office, but having the opportunity to get more promotion out in the community and others, another avenue in the next month or 2 to be able to provide those resources to community members. So this first one, as I mentioned, will be hosted on May 25th here in Yakima at Coastal Farm and Ranch. From 10 to 1 p.m. And the second event will be hosted in Sunnyside sometime in June. Commissioner Lindy, if you have any connections there, we'd sure appreciate it. We've had a little bit of trouble securing a location there. So.
Okay.
What were the dates again? For the first one will be May 25th from 10 a.m. to 1 p.m. here at the Coastal Farm and Ranch in Yakima. And the second one will be in June, and that is still to be determined.
Lillian, if you wouldn't mind just sending me a follow-up email.
Yes, absolutely.
Okay. I'll see what we can do.
We appreciate the assistance. And again, the intent with that is to provide these resources to people to ultimately prevent unintentional injury and harm. So we are planning on inviting other partners so that, again, with that area of focus in mind. And then my second update is a program I haven't talked about recently. So again, one of the programs at the Yakima Health District is called SNAP Ed, the Supplemental Nutrition Assistance Program. and education. Through that program, we've been working with different school districts, specifically Wapato, to help promote community gardens. And so the one in Wapato has taken off, and they have a partnership with some of the transition classes at the high school, which is, again, high school students with developmentally disabled, to participate and volunteer 2 hours a week and get those skill sets in working within the garden. We're wanting to do something similar in Grandview as well, and that's getting in the works. So through SNAP-Ed, the work that we do is essentially work with these different school districts to get volunteers, to get the resources and provide technical assistance. Most of the work and the legwork is happening at the schools and by the community members themselves. But what we do is, again, just broker the resources and kind of help get those projects going. But again, ultimately, these projects live within the school districts themselves. So we're hoping to be able to continue more of that, but for now it's working in Wapato and in Grandview. And then my last update is, again, in our work to help expand prevention work around opioids specifically, we had reached out to different organizations, like including Rod's House. And what Rod's House had identified is that what would help them do their work better is actually receiving some trauma-informed training. So we'll be helping to host a trauma-informed training, not just for Rod's House, but for other community-based organizations as well. These will be taking place in the month of May. We honestly had an overwhelming response of interest, so we are looking into hosting a third training as well. The training will be put on by the Community Resilience Initiative, which is based out of Walla Walla. These are half-day trainings for staff, again, to learn more about the how to provide trauma-informed care and understanding those principles to ultimately better support their own role within their organizations. So I will be happy to send that information out for those that are interested, especially since we're considering hosting a third training before the end of the year as well. And then just a quick update, again, a lot of the other work that we've been doing is supporting the coalition. So their events and the campaign is moving forward as discussed last month. But a quick reminder that this weekend is the Medication Take Back Day. There's several different locations across the county. There's 2 here in Yakima, 1 in Wapato as well. And again, the purpose of that is to make sure that people have a location to safely dispose of their medications that they have at home, to ensure that we limit the use for people, kids or others getting into them on accident, and making sure that they're getting rid of them. So that'll be taking place this weekend. And again, if anybody wants those specific dates and locations, I'm happy to send them over.
Lillian, a question on that. I know, for example, Sunnyside Hospital has a drop box, permanent drop box. Do we have other facilities that have those as well?
Yeah. Yes, that was actually an initiative a couple of years ago. We're actually pretty good in terms of geographic spread for Yakima. There's a couple different locations across Yakima Valley Farm Workers Clinic, the Sheriff's Office, a couple pharmacies as well. And there's a website where all of those are listed. Outside of that, because more recently, there's also the ability to get mail back options. So you can get envelopes to mail them back if you can't drive out to those locations as well. So there's several different options for people outside of these standalone events. You're absolutely right. That's it for me.
Any other questions for Lillian? If not, then we'll move on. Thank you. Next on the agenda is unfinished business, and Andre Fusco is going to talk about our deputy.
Yes, thank you so much. As we've discussed, we have Dr. Barr, who's provided us with tremendous support from a health officer standpoint. But we have also recognized, as we've discussed with the board in previous meetings, that we don't have a backup for Dr. Barr. One of the options was to work with the state. The state created a regional medical officer consortium, if you will, that we could access. The board had indicated that that might be an option of last resort, but the board was more interested in having someone who was local. I contacted a number of different local health jurisdictions to see if they would be willing to be a partner. Most were not able to do so. I did work with the Benton Franklin Health District that had a new health officer who has now departed. They then had a deputy, or rather a health officer interim role through the state regional medical office, who also departed. Our regional medical officer departed. So the state epidemiologist, Dr. Scott Lindquist, is always willing to help, but he is covering for Benton Franklin, or was, and then they have now contracted with a temporary health officer, but that health officer is not local. So we are finding a lack of options. And so one of the things that we had discussed with the board and members of the board had given interest to having a deputy health officer, which we can do. But I wanted to bring to the board's attention the process of doing that. The idea is to have a deputy health officer who could become well-versed in what we do, meets the criteria for being a health officer in the state, and is available for backup for Dr. Barg in the event of Dr. Barg having a need to not be here, which I think is fair. And also allows for continuity of services. One of the problems that we ran into was that there was a lot of bureaucracy with the state, and when they were talking about incidents, they were talking about signing forms or contacting people, and I said, emergencies happen in the middle of the night or on a holiday. And in crisis, you cannot expect to actually formulate a plan at that moment. You have to have 100% back. So I did have this conversation with our board chair, Mayor Byers, and so I wanted to bring to your attention what our thoughts were about a plan and gauge your interest in how to move forward. The board has shown their interest in having somebody local, which is what we're considering. Having a deputy health officer would allow us to, one, have backup, two, have more support, and also provide more training and experience to a local physician. Having said that, we could do one of two things. We could just simply create a contract with the health officer that we do, or it could be something that the board is involved with. So I wanted to have that discussion with the board. I want to make certain that the board is comfortable with moving forward with that. That's what the board had discussed with me, but I want to make sure that we have a plan. Any thoughts or considerations?
Any volunteers, Dr. Abbey?
I'm always happy to serve in any role I have. I think this is the 4th year of my citizen membership. And so transitioning into next year, I guess I would be potentially free. So I'm happy to put my name in the hat, if you will, for helping serve as a deputy, especially if I have Dr. Barg's phone number still available to me.
He's retiring, he may not be
He's always
available.
good. Well, he's always good about answering my texts and whatnot. So I can tell you that, yeah, I'd be happy to serve in any way I can, but whatever the board would like to do.
Thank you.
Responses from the board?
Well, I guess my response is thanks Dr. Atterbury for being willing to look at that. I mean, we have local options.
Well, the question for me is this something that you want the staff to direct and do, or as we've done with the process of appointing a health officer, would the board like to be involved in that process, which would require, some formality, interviews, public meetings and so forth? What would the board wish to do? Or would that something that you wish to do?
I guess I would say that the board's involvement in the last one seemed to help quite a bit, so I would suggest that same process be used in the future decisions.
I would concur. I think there's a place for the board involvement, just like we had the last time around. It makes sense. I mean, as far as the process, the recruitment and all that, that's going to be the health district's role, but we appreciate the opportunity to be involved, I think, along the way.
Well, we can start that process. We can discuss that internally and then bring that to your attention in our next board meeting.
So in that process, because Dr. Atterbury has volunteered to be part of this, you see that the health district would then just, kind of put out an invitation for people to apply, or we do appoint Dr. Atterbury and we move forward? How would that go?
Well, our normal process previously was to advertise it and then solicit interest, which I think would be fair. I'd like to confer with James in terms of the process. One of the things about discussing if you were interested would be your recusal as a board member, and also the question of timing, because really one of the things that we are concerned about in the midst of multiple initiatives is having access and backup. So this would be a deputy role. We'd have to really discuss, and we can again discuss with James about the role and how involved it is and what the limitations are of that role. The other piece is I would like to ask again, if things change at the state health level, that we do consider again having the health officer, the regional medical officer, as an additional backup. There are things that have to be accomplished under protocol here that we cannot do, that there are responsibilities that are required by a nurse that cannot be done without the protocol and coverage of the health officer. And if those things happen in the middle of the night, then we literally can't provide services. So I'd like to just point out to the board that would be ideal is to have our health officer, a deputy health officer, and in lieu of being able to reach either of those people, that the backup is this individual from the state.
That sounds reasonable.
Okay. And I want to share very candidly, the role of that individual is not to dictate or to create policy. It is to ensure the continuity of services. It's just that simple. Well, thank you. This is helpful.
Great. No other comment from the board? All right, we'll move forward. Next on the agenda is new business, and we have none. Which will bring us to our last agenda item, which is adjournment. Now we can entertain a motion to adjourn. Unless, of course, somebody has any business. Seeing none.
I would just make one comment. I wanted to make, it's not really a new business, more of an announcement. A very interesting ruling came out yesterday regarding, the Federal Trade Commission and non-compete, clauses that might affect a tremendous number of physician and healthcare organizations. I think it's an important thing to put out to the public to say, there's a lot of opinion about whether this would be a good or bad thing, and I don't want to put a position statement of whether it's a good or bad thing, but certainly it would allow access of physicians to come to our area, but it might also allow a loss of physicians from our area. So there's arguments to be made both for and against a non-compete clause ban in all of all employment, and specifically as it applies to healthcare. So we will see. I mean, this will be tied up in various lawsuits for years. However, it's an interesting decision as of yesterday that potentially has a large impact on almost 40% of physicians who are working under a non-compete currently and can't change jobs directly to the same area very easily as it is. But on the opposing side, many hospitals would say this is a terrible idea and very anti-competitive to themselves. So I won't put a position out there one way or the other. I'll just say it has the potential to affect healthcare access in our area. So I just throw it out there as a moment of thought. You can go read up on it yourself. The 300-page decision, so it'd take a while to read, but I did read a lot last night. Yeah. Yeah.
Or put your ass to sleep.
Yeah, right.
Yes.
Good bathroom reading. You know, it's good bathroom reading. So.
Yeah, that does was a very interesting section, so thank you.
Access, yeah.
Any other new business? If not, now I would entertain a motion to adjourn. We have a motion and a second to adjourn to our next scheduled meeting on May the 29th, 2024. All those in favor, please say aye.
Aye.
Aye. Any opposed? Thank you, Catherine, I heard you. All right, we are adjourned.
Thank you.